Welcome to today's deep dive. It is Tuesday, March 3rd, 2026. And, if you're joining us today, you are likely a dedicated learner.
Right, probably a medical student or maybe a junior doctor.
Yeah, exactly. Or a public health trainee, maybe a practicing clinician. You're looking to master the conceptual frameworks of public health. And, you are in exactly the right place.
Absolutely.
We're going to start by unpacking a conceptual metaphor that really serves as the foundation for everything we're going to discuss today. I want you to picture a fast-moving, treacherous, just violently churning river.
Okay, I can picture that.
Right, so clinical medicine is standing right on the muddy bank of that river, frantically pulling drowning people out of the water one by one. And it is essential, immediate, life-saving work.
You diagnose the drowning, you treat it, you resuscitate.
Yes, exactly. But public health operates on a completely different paradigm. Public health is not simply a clinic waiting for sick patients to just wash ashore.
No, it's much broader than that.
Right. It's the act of hiking miles upstream through really difficult terrain to figure out who or what is throwing these people into the river in the first place.
I love that.
And once it finds the source, public health is the immense structural effort of building a massive dam to stop it from happening entirely. It is fundamentally upstream engineering.
That framing perfectly captures the operational difference between the clinical level and the population level. And our mission for this deep dive is to explore exactly how that upstream engineering was developed conceptually, legally, and politically.
Yeah, which brings us to our source material.
Right. We are using the Oxford textbook of Global Public Health, specifically Chapter 1.2, as our structural spine today.
And just a quick note, you should absolutely read the Oxford chapter alongside this discussion.
Think of this as a companion piece. It's designed to clarify the frameworks, strengthen your reasoning, and really support your active reading.
Because this isn't just a recitation of historical trivia.
Not at all. It is a rigorous investigation into how societies literally engineer their own survival. We want to build clear conceptual frameworks for you, tracing the path from hazard and risk to exposure, to outcome, to intervention, and finally to system impact.
We're going to look past the what of historical events to deeply analyze the why and the how behind public health decisions, because progress in health is almost never an accident of nature.
Right. It is actively constructed, piece by piece, through profound crises, intense political negotiations, and sweeping social reforms.
So our roadmap for this deep dive is to trace the evolution of public health in developed countries through three distinct historical eras. First, we'll examine the reaction to crisis.
Then we'll look at the era of communal police.
Right. And third, we will explore the pursuit of human potential, which basically brings us right up to the modern welfare state. But before we get into the chronology, we need to address a fundamental enigma about public health itself. Well, we live longer, far healthier lives than our ancestors did. Periodic famines and deadly epidemics are, for the most part, historical concepts in high-income developed nations, yet the history of exactly how we engineered our way to this point is incredibly understudied.
Yeah, it really is. There's this pervasive false view that public health is just an uncontroversial, somewhat dry administrative function.
People picture, technicians testing the municipal water supply or bureaucrats collecting demographic data.
Right, or sanitation workers keeping the streets clean. It feels neutral.
Exactly, neutral, but that's a profound, almost dangerous illusion.
It is. The text brilliantly dismantles this by stating that public health is actually politics by medical means.
Politics by medical means. That's a powerful phrase.
Right. When we look at this history, we have to strip away that illusion of administrative neutrality and unpack three very troublesome historic themes or conceptual gaps that have always complicated this field.
Okay, let's break those down. What's the first one?
First, we have to establish the units of public health. Who are we actually talking about when we say the state versus the public? Historically, if we look back to the early modern period, the state's goals were absolutely not aligned with the biological well-being or the innate human rights of you, the individual citizen.
Because the mercantilist and early industrial states were primarily concerned with resource extraction.
And military dominance.
Yeah.
Therefore, they needed to ensure a steady supply of fit, capable laborers to run the factories.
And healthy, robust soldiers to fight the wars?
Exactly. The focus was entirely on the population as a utility, a resource to be managed for the preservation of the state itself.
I'm trying to visualize that relationship. It feels somewhat akin to a farmer managing a massive flock of sheep.
That's a great analogy.
Right. The farmer is highly motivated to protect that flock from wolves, to cure their diseases, and to ensure they're well fed. But that intervention isn't driven by a deep philosophical love for the individual rights of each sheep.
No, it's driven by the need to guarantee a high yield of wool at the end of the season.
Exactly. The state protected the population to maintain its own economic viability and geopolitical strength.
And understanding that utilitarian motive leads directly to the second troublesome theme, the condition of health itself. We have to ask, what actually causes disease at a population level?
Is it strictly a biological pathogen, a hazard that creates a biological risk? Or is the root cause poverty, squalor, and disenfranchisement?
Right. And when a disease outbreak occurs, where does society place the blame? This is where the concept of epidemiological causation becomes heavily entangled with political practicality.
Because the textbook notes that diseases have multiple antecedents. They're biological, yes, but they are also personal, social, cultural, political, and economic.
But the interventions a society actually chooses to fund and implement are always narrowed by what is politically feasible at the time and whose rights the state actually respects.
So a discussion of cause almost inevitably morphs into a discussion of responsibility and preventability.
Exactly. If we admit that poverty causes disease, then who is responsible for fixing the poverty?
Which brings us to the third theme, and perhaps the most complex one: health as authority. Why does public health so frequently get to claim the moral high ground in political debates?
Well, it does so because health is universally recognized as the supreme good of human existence. It claims a kind of biological universality.
But the historical reality is that actions taken under the banner of public health have routinely and actively discriminated by class, by race, and by gender.
Yes, the rhetoric of health for all has frequently served as a disguise for the fact that the state's interests were violently misaligned with the interests of marginalized communities.
Sometimes public health interventions genuinely saved lives.
And other times they were used to banish, imprison, or stigmatize populations, reflecting the distribution of political power rather than the biological reality of the actual threat.
Okay, so if we synthesize these three themes, the utilitarian goals of the state, the intensely political nature of disease causation, and the deployment of health as an unquestionable moral authority, we have the conceptual lens through which we must view our first major era.
Right. Phase 1. The public health of epidemic crisis.
And the defining characteristic of this entire early phase is that it was entirely reactive. There was no proactive upstream engineering yet.
Not at all.
Let's examine that reaction, because the initial historical response is genuinely surprising. I mean, a modern thinker might naturally assume that the moment human beings figured out a disease was contagious, they immediately implemented logical steps to stop it from spreading.
Right, you'd think so.
But the historical record shows that wasn't the case at all. If we look at ancient and classical responses, we see a prevailing attitude of deep fatalism. Take the plague of Athens in 430 BC.
Thucydides wrote an extensive, highly detailed account of that epidemic.
Yeah, and he clearly documented the phenomenon of contagion. He noted that doctors and caregivers were dying at the highest rates because they were in close proximity to the sick. They understood the mechanism of transmission.
But their societal response was essentially stoic resignation. The outbreak was attributed to the seasons, to miasma, or to the anger of the gods. Very few people actually fled the city. They largely just accepted their fate.
And similarly, classical Islamic medicine had developed an incredibly advanced science of hygiene, far surpassing Europe at the time.
But when the plague struck the Islamic world, it was widely interpreted as the direct will of Allah. Within that theological framework, actively intervening or fighting the plague was not just seen as futile, it was potentially impious.
The religious duty was to trust entirely in the divine plan, resulting in a profound epidemiological fatalism.
We really need to analyze that fatalistic framework carefully. It wasn't a lack of intelligence, it was a completely different conceptualization of risk and intervention.
So when did that shift?
The monumental shift away from that fatalism only really began to crystallize in late medieval Christian Europe, where we start to see the emergence of a new, highly specific kind of activism.
Even activism based on grace, right?
Exactly. The prevailing framework became dualistic. On one hand, the overarching cause of the disease was still viewed as a divine visitation, perhaps a test of faith or a collective punishment for societal sin. But on the other hand, The act of actively intervening, alleviating the suffering of the afflicted, and eventually trying to limit the spread, became viewed as an act of Christian grace and charity.
So you have a supernatural primary causation meeting a naturalistic secondary mitigation.
Yes. This was a profound conceptual evolution. It provided the necessary moral and theological permission required for the state and the local community to actually take action.
I want to dig into what that action actually looked like in practice, because it required building the very first public health institutions, which required some rudimentary systems thinking. Let's look at leprosy as a case study.
Leprosy is a fascinating example.
The societal response to leprosy was, in many ways, a massive overreaction. By the 13th century, there were thousands of leprosaria leper houses scattered across Europe.
But the fascinating part is the diagnostic process. The people deciding who had leprosy weren't trained medical doctors.
Right. They were usually churchmen or local magistrates. And they were isolating people not based on a strict biological understanding of how the mycobacterium transmitted, but largely on the visual, slow-developing, terrifying disfigurement caused by the disease.
Which highlights a crucial differentiation we need to make, the difference between a biological hazard and a perceived social risk. Leprosy is actually quite difficult to transmit. It requires prolonged, close contact.
But the visible nature of the disease made it a profound social terror.
Exactly. The policy of exclusion was about separating the religiously and physically unclean from mainstream society based on a loose, visually driven diagnosis. It was a crude form of structural intervention, driven more by stigma than by precise epidemiology.
Now, contrast that slow exclusionary process of leprosy with the Black Death, which struck Europe between 1347 and 1353.
The Black Death didn't just cause illness, it killed roughly a third of the European population in a matter of years.
It triggered a fundamental social collapse. When you read primary sources like Boccaccio's Decameron, it beautifully and tragically documents this total unraveling of social convention. Families abandoned each other, markets ceased to function, and the authority of both civil and ecclesiastical institutions completely shattered.
And that institutional shattering is the pivot point for public health history. When a society breaks down to that extreme degree, the state's very existence is existentially threatened.
Because a state cannot collect taxes, field an army, or enforce laws if a third of its population is dead and the rest are rioting or fleeing.
Precisely. So to maintain any semblance of authority, the state had to act. It couldn't just rely on the church anymore.
The conceptual takeaway here is how the state utilized a massive public health crisis to drastically expand its own power, jurisdiction, and bureaucratic reach.
Action became politically necessary not solely to save lives, but to violently demonstrate that the state apparatus was still functioning, still relevant, and still in charge of the surviving population.
And this expansion of state power leads to some brilliant, if draconian, innovations. This is where we see the invention of early warning radar for disease.
Specifically driven by the early modern Italian city-states like Venice and Florence.
Right, they were massive trading hubs, so they were highly vulnerable to imported pathogens.
They implemented the quarantina, the 40-day hold on arriving ships, which is where we get the word quarantine. They established complex protocols for fumigating goods, burning the clothing of the dead, and isolating victims in lazarettos.
But the detail that really highlights the system's thinking of this era concerns the concept of the embassy. Today, we view an embassy purely as a center for political and diplomatic relations.
Right.
But originally, the permanent embassy was essentially invented by these Italian city-states as a remote epidemiological monitoring station.
It was an incredible piece of intelligence gathering. Think about the mechanics of trade in the 14th and 15th centuries. If a merchant ship leaves the Levant and arrives in Venice carrying the plague, it's already too late.
The hazard has been introduced into the population.
Exactly. So the Venetian state realized they needed to move their surveillance upstream. The primary functional purpose of early permanent ambassadors was to keep a hypervigilant eye on the health conditions of the host country.
If an outbreak of plague was detected in Constantinople or Cairo, the ambassador would immediately dispatch fast couriers back to Venice.
Which allowed the Venetian magistrates to close their ports and enact quarantine protocols before the infected ships arrived. They were literally setting up a biological early warning system.
It is a perfect early example of transitioning from purely reactive medicine to proactive structural intervention.
It's a brilliant strategic move. But of course, these actions, closing ports, burning goods, locking people in lazarettos, inevitably sparked a massive historical tension that remains highly relevant today.
It is the fundamental conflict between absolute individual liberty and overarching state control.
When does the state have the right to violate your personal freedom in the name of collective security?
The textbook highlights this tension beautifully by examining the historical response to three specific diseases: syphilis, smallpox, and continued fever, which we now recognize as typhus or typhoid. Let's analyze syphilis first.
Syphilis perfectly illustrates the intersection of public health, state power, and gender disparity. By the 19th century, syphilis had become a major strategic problem for the state because it severely threatened military readiness.
A high percentage of soldiers and sailors were incapacitated by venereal disease.
In the United Kingdom, this strategic panic led directly to the passage of the Contagious Diseases Acts, beginning in 1864. And this is a textbook example of that moral authority we discussed earlier being deployed in a highly discriminatory manner.
I want to make sure we are looking at this impartially and understanding the exact mechanics of the law. How did the Contagious Diseases Acts actually operate on the ground?
The operational mechanics were inherently unequal. The acts empowered plainclothes police officers in designated garrison towns and naval ports to identify women they presumed to be prostitutes.
Presume?
Yes, presumed. These women could then be arrested, forced to undergo highly invasive medical inspections, and if found to be infected with a venereal disease, they could be forcibly confined in a locked hospital ward, essentially a prison for up to a year.
Wow. And the stated utilitarian goal of the state was to protect the male soldiers from infection.
Exactly. However, the double standard was legally glaring. The male soldiers, who were equally carriers and transmitters of the disease, were not subjected to the same forced inspections or confinement.
The underlying political premise was that male citizens, even working-class soldiers, simply would not tolerate such a gross violation of their civil rights.
Correct.
And that blatant legal inequality didn't go unnoticed, did it? It triggered a massive backlash.
It did. It sparked one of the first major human rights and feminist campaigns of the Victorian era, led by figures like Josephine Butler. The opposition was a diverse coalition. They argued that the state was effectively sanctioning male vice while brutalizing and stigmatizing working-class women.
They pointed out the hypocrisy of ignoring male culpability in the chain of transmission.
The political pressure became so intense that the acts were eventually repealed in 1886. But conceptually, it remains a stark, vital historical example of how public health policy, when driven purely by state utility, can violently collide with civil liberties and the principle of equality before the law.
We see another massive collision of individual rights and state power with smallpox, but this time the core issue isn't gender. It's the concept of trust and bodily autonomy. Smallpox was a devastating, terrifying disease, particularly for children. The mortality rate was horrific.
And initially, the method of prevention was entirely a personal choice. Back in 1721, Lady Mary Wortley Montagu famously observed the practice of variolation in the Ottoman Empire and introduced it to Western Europe.
This involved deliberately infecting a healthy person with material from a mild smallpox patient, hoping to induce a mild case and subsequent lifelong immunity. It was risky, but it was a personal calculation of risk versus benefit.
Then, in 1798, Edward Jenner made his massive breakthrough, developing the much safer cowpox vaccination. It was a scientific miracle.
But the tension arises when the state decides that a personal choice must become a mandated obligation.
That transition from voluntary adoption to state mandate is critical. The British government, recognizing the immense public health benefit of Jenner's vaccine, eventually made infant vaccination legally mandatory with the Vaccination Act of 1853, and subsequent acts introduced strict fines and even imprisonment for parents who refused to comply.
And what was the outcome?
An immense, highly organized public pushback.
Which seems deeply counterintuitive. Why would a population violently resist a medical intervention that objectively saves their children from a horrific death?
To understand the resistance, we have to look at the dynamics of trust and the perception of risk. When the state forces a medical procedure, particularly one that involves inserting biological material into an infant, public distrust naturally skyrockets.
Especially among the working class population.
Yes, who were the primary targets of enforcement.
Right.
They already viewed the state with deep suspicion. The state was the entity that enforced the harsh poor laws and poor working conditions.
So, when this same state suddenly demanded the right to vaccinate their children under threat of prison, many viewed it not as a benevolent health measure, but as another form of tyrannical overreach.
The harder the state pushed, the more the anti-vaccination leagues grew, arguing for bodily autonomy and parental rights. The resistance was so fierce and the civil disobedience so widespread that the government was eventually forced into a compromise.
And that's when they introduced the legal concept of the conscientious objector in 1898.
Exactly, allowing parents who possessed a sincere moral or philosophical objection to legally opt out of the mandate. The vital conceptual lesson here is that public health interventions cannot succeed purely on their scientific or epidemiological merit. They absolutely require a bedrock of public trust.
If you rely solely on coercion, the system fractures.
It always does.
That brings us to the third disease in this historical tension, typhus. And the story of typhus completely exposes the intractable link between disease and poverty. In 1848, a devastating outbreak of typhus hit the region of Upper Silesia, which was then part of the Prussian Empire.
The government sent a young, radical physician named Rudolf Virchow, who would later become an absolute legend in the history of medicine and pathology, to investigate the epidemic and propose a solution.
Virchow's investigation in Silesia is a masterclass in upstream thinking. When he arrived, he didn't just look at the clinical pathology of the patients. He conducted a comprehensive socioeconomic audit of the region.
He looked at the Polish minority population who were suffering the most.
Yeah.
He analyzed their lack of political representation, the oppressive taxation system, the failure of the local agriculture, and the appalling, squalid housing conditions they were forced into.
And his final report was explosive, wasn't it? He didn't just say, here's the biological mechanism of the fever, and here is the medical treatment.
Exactly the opposite. He diagnosed the epidemic fundamentally as a political failure. He explicitly stated that the biological disease was merely the final outcome of a long chain of social and economic deprivation.
He famously argued that the squalor causing the typhus could not be cured by medicine alone. It could only be fixed by sweeping liberal political and economic reforms.
He called for a democratic constitution, universal education, and agricultural freedom. To Virchow, political reform wasn't just tangentially related to health. Political reform was the primary medical antidote. He viewed medicine as a social science and politics as nothing more than medicine on a larger scale.
Virchow's radical analysis perfectly bridges us to our second major historical era. Phase 2, the public health of communal life, or what was known in the historical terminology as the era of police.
Now, we need to clarify our terms immediately. When we use the word police in the context of the 18th century, we are absolutely not talking about detectives fighting crime or uniformed officers arresting burglars.
No, the etymology is different. The concept of police in this era derived from the Greek polis, meaning the city or the state.
It referred to the broad, overarching administration of internal public order. It was the vast, complex, bureaucratic apparatus dedicated to regulating almost every aspect of the shared communal environment.
This included monitoring market weights and measures to prevent fraud, managing the disposal of animal dung and human waste from the streets, ensuring the structural safety of buildings, and even licensing practitioners like midwives and apothecaries.
I think there's a huge modern misconception that medieval and early modern cities were simply lawless, anarchic mud pits where everyone just threw their garbage out the window.
But the historical record shows they actually had highly sophisticated, albeit localized, institutions for managing urban life.
For example, in the medieval Islamic world, there was the role of the mutasib. This was a high-ranking civic official whose explicit duty was to oversee commerce in the bazaars, ensure the cleanliness of the streets, regulate refuse disposal, and monitor the public baths. They were essentially early environmental health officers.
In England, you had community-based legal systems like the leet juries. These were groups of local citizens who would routinely walk the boundaries of the town, identify environmental problems like a blocked ditch or a foul-smelling tannery, and report them to the local magistrates for action.
You also had specialized courts of sewers dedicated entirely to resolving complex disputes over drainage and water flow.
What is conceptually fascinating about these early systems is how they conceptualize the problem. They didn't have a germ theory of disease. So how did they legally justify intervening in environmental health?
They did it through the evolution of the concept of the nuisance. In the Anglo-French common law tradition, a nuisance was not initially categorized as a public health violation. It was strictly a civil trespass.
The legal maxim was essentially, use your own property so as not to injure another's.
Right. If your poorly constructed chimney was billowing thick smoke into my windows, or if your pigsty was draining effluent onto my land, you were offending my property rights and my right to the quiet enjoyment of my land.
Notice the pattern recognition here. Early environmental public health didn't originate with physicians looking through microscopes for bacteria. It originated with lawyers and local magistrates attempting to resolve property disputes.
It was fundamentally about neighborly amenity and maintaining a tolerable, functional communal environment.
I'm trying to square this. How does a local property dispute about a smoky chimney eventually evolve into the foundation for a national health department? It seems like consumer demand and economic outrage were actually driving health improvements long before epidemiology was formalized as a science.
That is an incredibly astute observation. And it's true. The general public didn't start demanding clean municipal water supplies because an epidemiologist like John Snow showed them a statistical map of cholera cases.
They demanded clean water, unwatered ale, and honest weights at the butcher's stall because they were consumers who were tired of being economically cheated and sold adulterated goods.
The demand for environmental purity and safe food was an economic outrage and a moral demand for fairness first, and it only became codified as a medical intervention much later.
But as we move toward the late 18th century, the scale of this regulation changes drastically. We see a transition from localized, property-based nuisance laws managed by local juries to massive, overarching state bureaucracies. This is the phenomenon of the medicalization of the state.
Yes, and the prime historical architect of this shift is Johann Peter Frank, working in Germany and Austria. Between 1779 and 1819, Frank published an exhaustive, monumental 6-volume work titled A System of Complete Medical Police.
Frank was a staunch proponent of a political philosophy known as cameralism.
Cameralism is a deeply authoritarian, paternalistic view of state governance. It posits that the ultimate wealth and power of a nation depend entirely on the size, health, and productivity of its population.
So under a cameralist framework, the state essentially says, if any activity affects the health of the population, it is no longer a private matter. It is the absolute business of the state.
Frank's volumes didn't just cover sewers and markets. They were unbelievably comprehensive. He proposed state regulation of the institution of marriage, the management of public amusements and theater, strict dietary guidelines, the architectural layout of private buildings, and even the minute details of pregnant women's health and infant care.
The underlying philosophical idea was that the individual citizen's freedom, or their property rights, were entirely subordinate to the state's overarching need to maintain a robust, biologically healthy population.
It is the ultimate expression of the state viewing the public merely as a biological resource to be managed, regulated, and intensively policed for the state's own benefit and military readiness.
And understanding that extreme authoritarian framework is essential because it sets up the massive philosophical pivot that defines our third and final major era, Phase 3, the pursuit of human potential.
This phase represents a monumental, seismic shift in human history. It is the moment when society slowly begins to adopt the belief that human health is not just a utilitarian resource for the state's military, but something that actually could and ethically should be proactively improved for the inherent benefit of the individual human being.
Because this era is so expansive, we are going to break it down into 3 distinct parts. Let's begin with Phase 3, Part A, the age of liberalism and the sanitary idea, which spans roughly from 1790 to 1880.
This period is catalyzed by a statistical revelation. For the first time in history, reformers and bureaucrats are systematically gathering hard demographic data and mathematically proving the existence of excess mortality.
They are showing, with undeniable numbers, that people living in the overcrowded, squalid urban slums of the Industrial Revolution are dying at vastly higher rates than people living in rural areas or affluent neighborhoods.
Now, looking at this from a modern perspective, you would assume that publishing this horrific data would instantly trigger a wave of humanitarian compassion and immediate government intervention.
But that wasn't the case at all. Early in this period, the dominant intellectual framework was liberal Malthusian fatalism.
We need to unpack Malthus to understand the resistance to public health. The Reverend Thomas Malthus and his economic followers believed that human population growth would always inevitably outpace the production of food.
Therefore, they argued that poverty, famine, and deadly disease were not tragedies to be solved, but rather vital natural checks on overpopulation.
Their logic was cold and mathematically harsh. If the state intervenes to improve sanitation and save the lives of the poor now, you will simply have a larger starving population competing for the same limited resources a generation later.
Therefore, the most rational, albeit brutal, policy was non-intervention. Let nature take its course to balance the population.
But that Malthusian fatalism eventually runs into a massive political brick wall in the 1830s and 40s. And it wasn't defeated by compassion. It was defeated by fear.
The rapidly expanding, deeply alienated, diseased, and impoverished underclass living in these horrific urban industrial centers suddenly became a massive, existential political threat.
Governments in Britain and across Europe were absolutely terrified of the prospect of violent revolution. The cholera epidemics of this era highlighted the fragility of the social order.
The ruling classes realized that a massive urban population living in disease-ridden, subhuman conditions wasn't just an abstract economic statistic, it was a ticking time bomb of social unrest.
You simply cannot maintain a stable, productive, liberal industrial economy if your primary workforce is constantly decimated by epidemics and prone to violent political uprising.
That political terror created the perfect opening for one of the most consequential figures in public health history, Edwin Chadwick.
Chadwick was a British social reformer and a highly pragmatic administrator. He became the primary champion of what was called the sanitary idea.
But Chadwick was a brilliant political strategist. He knew he was dealing with a parliament full of Malthusians and fiscal conservatives. He knew he couldn't sell them on funding massive, unprecedented, highly expensive infrastructure projects like citywide glazed pipewater and sewerage systems based purely on humanitarian compassion or abstract human rights.
They wouldn't vote for it.
So instead of arguing compassion, he argued raw economics. He found an accounting loophole.
Precisely. He framed the problem around the New Poor Law of 1834, which he had helped design. The state was obligated to provide basic welfare poor relief to destitute widows and orphans.
Chadwick conducted massive surveys and pointed out a glaring economic inefficiency. He showed that when male breadwinners in the slums died prematurely of preventable filth diseases like typhus or cholera, their surviving families immediately fell onto the state's poor relief system.
Chadwick successfully argued to Parliament that the upfront capital cost of building municipal sewers to save those breadwinners' lives would actually save the state money in the long run by drastically reducing the ongoing compound burden of welfare costs.
It was a utilitarian argument. The greatest good for the greatest number, justified by a reduction in taxation.
And here is the absolute ultimate irony of Chadwick's sanitary idea, which perfectly illustrates the concept of mechanism over exact science. Chadwick's entire justification, his whole sanitary system, was based on a completely, fundamentally incorrect scientific premise.
He was a staunch believer in the miasma theory. He believed that disease was caused by foul air, by inhaling the bad smells and toxic vapors emanating from rotting organic matter in stagnant cesspools.
He had no concept that microscopic germs existed. The underlying science was entirely wrong.
Yet the structural intervention he aggressively pushed for, the engineering feat of continuously flushing sewage out of the cities through glazed pipes and bringing in a constant supply of clean, filtered water, actually worked miracles.
It achieved massive public health victories because, entirely by accident, his infrastructure was physically removing the waterborne bacterial pathogens like Vibrio cholerae that actually caused the diseases.
The pattern recognition here is profound for public health practitioners. Sometimes a robust, sweeping structural reform that alters the physical environment outperforms a perfect medical theory.
You don't always need to map the genome of the pathogen if you can physically engineer the hazard out of the environment.
It's a great reminder that you don't always need to know exactly how the engine works on a molecular level to know you need to change the oil. Now, throughout this entire age of liberalism, there was an intense, highly polarized, ongoing debate about exactly how much the state should be allowed to intervene in the private lives and businesses of its citizens to achieve these health outcomes.
And we're going to look at this impartially, because the core arguments of this debate echo perfectly into modern political discourse.
Indeed, this is a foundational political tension. On one side of the debate, you had the staunch proponents of the absolute free market and laissez-faire economics.
Their philosophical argument was that adult citizens must have the absolute liberty to bargain for their own labor, agree to work whatever hours they choose, whatever conditions they accept, and manage their own lives without state interference.
They viewed government intervention in factory working conditions, child labor laws, or mandated housing standards as the creation of a tyrannical nanny state.
They argued this would inevitably breed dependence, stifle economic innovation, and strip individuals of their agency and moral responsibility.
And on the opposing side, the social reformers and early public health advocates argued that true liberty has biological prerequisites.
Their counterargument was that you cannot meaningfully participate in a free market or exercise your civil liberties if you are physically debilitated by toxic factory conditions, exhausted by 14-hour workdays, or forced to live in a windowless tenement that guarantees respiratory illness.
They argued that a purely unregulated free market naturally produces biological exploitation, and therefore, state intervention is absolutely necessary to establish a baseline of human biological welfare.
This intense debate over the balance between free market autonomy and the necessity of state regulation to prevent biological harm laid the fundamental philosophical groundwork for how modern democratic systems view health, labor, and regulation today.
And the parameters of that debate evolve significantly as we move into the next phase. Phase 3, Part B, the Golden Age of Public Health, spanning roughly from 1880 to 1970.
This is the era where laboratory science truly takes the wheel, fundamentally altering the trajectory of public health. We see the explosive rise of bacteriology, the deeply troubling and dark pseudoscience of eugenics, and the beginnings of complex nutritional science.
All unfolding under a massive resurgence of state power and global competition. Let's set the geopolitical stage for this golden age. Nations were fiercely competing for global dominance, industrial supremacy, and colonial expansion.
To maintain empires, you need massive armies. When these nations, particularly Britain during the Boer War and later in World War I, started conscripting hundreds of thousands of young men, the military medical boards were absolutely horrified by what they found.
They discovered incredibly high rates of severe physical unfitness, chronic malnutrition, and preventable disease among the working-class recruits. The nation's human resources were degraded.
This strategic shock sparked a hyper-focus on the individual human body. It was no longer just about cleaning the streets, it was about optimizing the citizen.
This shift to the micro level is scientifically defined by the bacteriological revolution, most famously driven by the germ theory, pioneered by figures like Louis Pasteur and Robert Koch. They proved that specific, identifiable microscopic organisms cause specific diseases.
This required a crucial, fundamental differentiation in public health strategy. Remember, Chadwick's sanitary movement focused almost entirely on cleaning the external environment, the macro level of pipes and water.
Bacteriology, however, abruptly shifted the focus to the human carrier, the micro level of the individual.
Because if microscopic germs cause disease and humans carry those germs, then the individual person carrying the pathogen becomes the primary threat to the broader community.
This conceptual shift brings us to one of the most famous and complex figures in the history of public health, Mary Mallon, widely known by the moniker Typhoid Mary.
Her case is the ultimate stress test of these new bacteriological concepts. Mary Mallon was an asymptomatic carrier of the typhoid bacterium.
This was a completely novel concept at the time, the idea that someone could feel perfectly healthy, exhibit absolutely no symptoms, yet still shed a deadly pathogen.
She worked as a private cook for wealthy families in New York, and she inadvertently infected dozens of people, causing several deaths.
When public health officials, utilizing the new tools of epidemiology and bacteriology, finally tracked the outbreaks back to her, the resulting action highlighted a massive ethical dilemma.
Because she refused to stop cooking, which was her livelihood, and didn't believe she was sick, the state essentially imprisoned her. She spent a total of 26 years forced into medical isolation on North Brother Island by the city of New York.
Her case is the ultimate ethical collision. It is the direct trade-off between the fundamental civil rights of an individual who hasn't committed a crime in the traditional sense and doesn't even feel ill, and the absolute mandate of the state to protect the broader public from a demonstrably deadly biological hazard.
It forces us to ask, how far can the state go to neutralize a human vector?
That focus on the biological quality of the individual citizen during this era also led public health down a profoundly dark, catastrophic path: eugenics. As students of public health, it is vital to analyze this historically, clinically, and objectively, so we understand how the mechanisms of scientific authority can be corrupted.
Drawing direct inspiration from the immense, measurable successes in agricultural, animal breeding, and crop yields, many leading political, scientific, and academic figures of the early 20th century adopted a terrifyingly utilitarian view of human genetics.
They believed, with absolute scientific arrogance, that they could cure complex societal issues like poverty, perceived feeble-mindedness, criminality, and social decay by applying those same agricultural breeding principles to human populations.
This manifested primarily as negative eugenics, the active, state-mandated prevention of reproduction among those specific groups the state deemed to be biologically or socially inferior.
And we must emphasize that this was not just a fringe radical theory. Eugenics was mainstream, widely accepted, highly funded scientific reasoning at the time, endorsed by major universities and progressive reformers alike.
We can track this ideological lineage directly from early 20th century American legislation, which resulted in the forced, legal sterilization of tens of thousands of citizens labeled as feeble-minded, habitually criminal, or promiscuous straight across the Atlantic.
That exact same public health logic, that framework of biological utilitarianism, was then adopted, expanded, and taken to its most horrific, catastrophic extreme by Nazi Germany.
The Holocaust and the implementation of the death camps were perversely, yet systematically framed by the Nazi regime as a form of state medicine. They explicitly utilized the vocabulary and authority of public health, comparing marginalized populations to a biological cancer or an infectious pathogen that had to be excised from the societal body to legally and morally justify genocide.
It is a permanent, chilling warning for public health ethics. It demonstrates with horrifying historical clarity exactly what happens when the universal moral authority of health is weaponized, completely detached from the foundation of individual human rights, and married to unchecked authoritarian state power.
The overarching pursuit of a healthy population can never, ever be ethically divorced from the dignified treatment of the individual human being.
Following that dark period, we also see another major scientific advancement in this golden age, of the rise of nutritional science. Scientists began discovering vitamins and successfully linking devastating diseases like pellagra, scurvy, and rickets to highly specific dietary deficiencies rather than infectious germs.
This was a massive conceptual breakthrough in understanding disease causation. But paradoxically, it also placed an immense, highly gendered new burden on the everyday citizen, particularly mothers.
The translation of this new science into public policy resulted in a massive expansion of domestic regulation. Suddenly, to be considered a good citizen and a responsible mother by the state, you had to manage an exhausting, complex list of hygienic demands.
You were expected to constantly disinfect the home using new chemical products, strictly regulate your family's daily diet to ensure invisible, trace nutrients were present, monitor infant weight charts, and practice intense lifestyle discipline.
The state, through its public health nurses and literature, was constantly advising, admonishing, and expecting the individual household to uphold a highly rigid, scientifically mandated standard of living.
It was a subtle but profound shift of responsibility from the state's infrastructure back onto the individual's daily behavior.
Which perfectly sets the stage for our final era, Phase 3, Part C, the return of liberalism, spanning from roughly 1970 to the present day. I know we've covered a vast amount of history, but this modern era requires massive analytical weight because it defines the environment we work in today.
As the 20th century progressed, the massive acute threats of traditional infectious diseases like polio, smallpox, and cholera began to significantly recede in the developed world.
This was largely thanks to the triumphs of mass vaccination programs, the discovery of antibiotics, and deeply entrenched improvements in sanitation. But nature abhors a vacuum.
As those acute infectious threats retreated, chronic and lifestyle-related diseases like cardiovascular disease, type 2 diabetes, chronic respiratory illnesses, and various cancers rose rapidly to take their place as the primary drivers of mortality.
And this epidemiological transition creates a fascinating, deeply complex modern tension. In 1968, the World Health Organization made a monumental declaration. They stated that the highest attainable standard of health is a fundamental human right.
So philosophically and legally, the state owes you the conditions for health. But the paradox is that achieving that health in the modern era largely requires you, the individual citizen, to drastically change your personal daily behavior.
It requires you to quit smoking, to exercise regularly, to reduce alcohol consumption, to eat less processed fat, to wear a seatbelt. So we are left with a massive conceptual clash between the autonomy of the individual and the obligations of the state.
I want to push back on this dynamic because it feels inherently contradictory. Is it not a form of victim blaming when government public health department tells an alienated, highly stressed citizen who is perhaps working 2 minimum wage jobs and living in a food desert that they simply need to eat better, make smarter choices, and go to the gym?
Especially when, at the exact same time, that very same government is heavily subsidizing the agricultural production of cheap, high-fructose corn syrup and allowing the tobacco and fast food industries to aggressively market their products to that exact demographic.
You've identified the core contradiction of modern public health. It is a profound structural hypocrisy. The state demands individual behavioral modification while simultaneously maintaining the macroeconomic conditions that make those unhealthy behaviors the most rational or accessible choices for the poorest citizens.
And this era also saw the necessary rise of environmentalism 2.0, which further complicates the state's role. We need to clearly differentiate this modern environmentalism from the 19th century sanitary movement.
Edwin Chadwick was fighting organic waste horse dung, human sewage, rotting vegetables. That was a communal problem. Everyone produced it, and the state's job was simply to build pipes to wash it away.
But 20th and 21st century environmental health is fighting complex synthetic hazards, toxic waste, industrial radiation, microplastics, and forever chemicals like PFAS.
And unlike horse dung, those synthetic hazards are largely a corporate problem, not a communal one. They're the byproducts of massive, politically powerful industries.
Exactly. And this causes a massive ongoing erosion of public trust. Why? Because the state is often correctly viewed by the public as being complicit with the very polluters who are creating the health hazards.
The state grants the permits, subsidizes the industries, and often fails to enforce environmental regulations. The public health apparatus, because it is a branch of the government, struggles immensely to police massive multinational chemical corporations in the same straightforward way an 18th century local magistrate could police a local butcher for selling rotten meat.
The power dynamic has completely inverted. This all culminates in the most complex system impact of the modern era, the structural merging of public health with the massive apparatus of the welfare state.
We see this manifested in the creation of comprehensive systems like the National Health Service in the UK or the Veterans Administration and Medicare and Medicaid in the US. There is a final overarching realization that public health cannot be artificially siloed off from clinical care, nor can it be separated from social support systems.
This is the realization of what we now formally call the social determinants of health. The epidemiological data is unequivocal. Your zip code is often a better predictor of your life expectancy than your genetic code.
Public health outcomes are inextricably linked to systemic factors like generational poverty, housing quality, access to early childhood education, and environmental justice.
You cannot simply instruct a population to be healthy if the structural, economic, and political realities of their daily lives make health physically and psychologically impossible.
The welfare state was an attempt to engineer a baseline of social security to mitigate those determinants. But as we see today, that system is under immense financial and political strain.
That brings us to a final, provocative thought to leave you with before we test your knowledge. The textbook chapter concludes with a truly powerful, almost unsettling observation. Without a shared moral and political philosophy, public health is frequently forced to hide behind contested science.
Think deeply about the long trajectory we've covered today. If the 19th century was fundamentally defined by the engineering struggle to build physical infrastructure, like the massive sewer networks and clean water reservoirs,
And the 20th century was defined by the struggle to build medical infrastructure like mass vaccination supply chains, laboratory networks, and national health services.
then perhaps the true existential public health crisis of the 21st century is fundamentally informational and relational.
We are living in an era defined by profound, pervasive institutional distrust. The public is deeply skeptical of pharmaceutical companies, of scientific modeling, and of government mandates.
So the ultimate question for the modern practitioner is this: how does public health build immunity against skepticism, disinformation, and apathy when the state apparatus itself is no longer implicitly trusted by the very public it is trying to protect?
It is no longer just a challenge of mapping epidemiology or engineering better vaccines. It is fundamentally a challenge of engineering trust, communication, and shared values in a highly fractured society.
That is an immense concept to chew on. How do we engineer trust in a fractured world?
Okay, it is time for our learning reinforcement segment. We want to solidify this conceptual framework and make sure these historical lessons are permanently anchored for you. I am going to ask 6 rapid single best answer or SBA-style questions based on everything we just discussed. I will pause briefly after each question so you can actively lock in your answer, and then we will provide the correct response and tell you exactly where in the chapter to look if you need a refresher. Are you ready? Let's test your pattern recognition. Question 1. What was the primary successful political motivation behind Edwin Chadwick's 19th century sanitary movement? A. Implementing the newly discovered germ theory of disease. B. Establishing universal human rights and bodily autonomy for the working class. C. Reducing the state's financial burden of poor relief by preventing the death of male breadwinners. D. Combating the newly identified effects of industrial, highly processed nutrition.
The answer is C. Reducing the state's financial burden of poor relief. Remember, Chadwick utilized utilitarian economics and accounting loopholes, not just compassion, to justify massive infrastructure spending. You can revisit the Age of Liberalism section of the text to consolidate this concept.
Question 2. How did the rapid rise of bacteriology fundamentally alter public health strategies compared to the earlier sanitary movement? A. It shifted the primary focus from cleaning the external environment to identifying and managing human carriers. B. It prioritized broad town planning and architecture over specific medical intervention. C. It completely eliminated the need for clean municipal water supplies. D. It resulted in the immediate dismantling of all historical quarantine laws.
The answer is A. It shifted the primary focus from the environment to identifying human carriers. This was the conceptual shift from fixing the macro-level pipes to finding the micro-level vector like typhoid Mary. Revisit the Golden Age of public health to review this shift.
Question 3. Johann Peter Frank's concept of medical police is best characterized by which of the following political frameworks? A. A grassroots bottom-up consumer movement demanding pure food and honest weights. B. An authoritarian, cameralist approach where the state heavily regulates daily private life to maintain a strong biological population. C. The first democratic parliamentary consensus on funding universal health care. D. The strict legal separation of clinical medicine from any state oversight.
The answer is B. An authoritarian, cameralist approach where the state heavily regulates daily life. This was the ultimate expression of the state managing the biological resources of its people for its own power. Revisit the Public Health of Communal Life Police for more on Frank and cameralism.
Question 4. In early Anglo-French legal traditions, the concept of a nuisance originally functioned as what? A. A strict criminal offense punishable by the national government. B. A biological vector identified by early microscopists. C. A civil property dispute regarding neighborly annoyance or interference with property rights. D. A highly specific medical diagnosis for continued fever.
The answer is C. A civil property dispute regarding annoyance or interference with rights. Remember the pattern. Early environmental public health began in many ways as localized property law. Revisit the Public Health of Communal Life Police to review the origins of nuisance laws.
Question 5. Rudolf Virchow's 1848 investigation of typhus in Upper Silesia concluded that the most effective public health intervention would be A. The immediate mass quarantine of the affected Polish minority population. B. Sweeping liberal political and economic reforms to address the underlying squalor. C. The rapid development and distribution of a targeted biological vaccine. D. Strict municipal regulation of the local meat and produce markets.
The answer is B. Liberal political and economic reforms. Virchow diagnosed the epidemic as a fundamental political failure of squalor, poverty, and disenfranchisement. Revisit the Public Health of Epidemic Crisis reaction for this crucial moment in socio-medical history.
Question 6. Which specific historical threat most directly catalyzed the creation of the permanent state embassy as an early warning public health surveillance system? A. The devastating 19th century cholera pandemics originating in India. B. The rapid spread of syphilis in the late 15th century. C. The threat of plague importation in the early modern Italian trading city-states. D. The widespread identification of pellagra in rural agricultural communities.
The answer is C. The threat of plague in the early modern Italian city-states. The permanent embassy was essentially invented as a biological early warning radar to allow time to enact quarantine protocols. Revisit the Public Health of Epidemic Crisis reaction to review this brilliant piece of upstream systems thinking.
And that wraps up our structural deep dive into the history and development of public health. We've hiked a long way upstream together today, from Stoic fatalism to the modern welfare state. Thank you so much for listening, for challenging your assumptions, and for doing the deep, necessary work of learning. We will see you next time. Here are the details of this episode. GPH 2, the history and development of public health in developed countries. Here are the details of this episode. Byline. Here are the details of this episode. From cholera streets to welfare states, how crisis, science, and reform shaped modern public health. Here are the details of this episode. Episode description. Here are the details of this episode. Public health did not emerge in lecture theaters. It emerged in overcrowded cities, in the shadow of epidemics, and in response to social upheaval. Here are the details of this episode. In this episode, we trace the development of public health in high-income countries, from the sanitary movement of the 19th century to the institutionalization of welfare states in the 20th. We explore how industrialization, urbanization, and poverty created conditions for infectious disease outbreaks, and how reformers used data, political advocacy, and engineering solutions to transform cities. Figures such as Edwin Chadwick and John Snow symbolize two essential public health tools: structural reform and epidemiological reasoning. The sanitary revolution sewage systems, clean water, housing reform dramatically reduced mortality long before antibiotics became available. Figures such as Edwin Chadwick and John Snow symbolize two essential public health tools. The episode then moves into the bacteriological era, where germ theory refined understanding of causation and catalyzed vaccination programs and surveillance systems. We examine how the expansion of state responsibility for health in the 20th century laid foundations for national health systems, regulatory frameworks, and social protection policies. Figures such as Edwin Chadwick and John Snow symbolize two essential public health tools. Importantly, we also reflect on the tensions that accompanied this evolution debates about state intervention, personal liberty, and the role of medicine versus prevention. Public health in developed countries evolved through crisis, political negotiation, scientific advancement, and moral commitment to collective well-being. Its trajectory reveals a central lesson. Progress in health is rarely accidental, it is constructed. Public health in developed countries evolved through crisis, political negotiation, scientific advancement, and moral commitment to collective well-being. Its trajectory reveals a central lesson. Public health in developed countries evolved through crisis, political negotiation, scientific advancement, and moral commitment to collective well-being. Its trajectory reveals a central lesson. Key takeaways. Public health in developed countries evolved through crisis, political negotiation, scientific advancement, and moral commitment to collective well-being. Its trajectory reveals a central lesson. Industrialization and urbanization were catalysts for modern public health systems. Public health in developed countries evolved through crisis, political negotiation, scientific advancement, and moral commitment to collective well-being. Its trajectory reveals a central lesson. The sanitary movement preceded and outperformed early medical therapies in reducing mortality. Public health in developed countries evolved through crisis, political negotiation, scientific advancement, and moral commitment to collective well-being. Its trajectory reveals a central lesson. Epidemiology emerged as a powerful investigative and advocacy tool. Public health in developed countries evolved through crisis, political negotiation, scientific advancement, and moral commitment to collective well-being. Its trajectory reveals a central lesson. Germ theory refined causal understanding and strengthened prevention strategies. Public health in developed countries evolved through crisis, political negotiation, scientific advancement, and moral commitment to collective well-being. Its trajectory reveals a central lesson. The rise of welfare states institutionalized public responsibility for health. Public health in developed countries evolved through crisis, political negotiation, scientific advancement, and moral commitment to collective well-being. Its trajectory reveals a central lesson. Public health progress depended on political will as much as scientific evidence. Public health in developed countries evolved through crisis, political negotiation, scientific advancement, and moral commitment to collective well-being. Its trajectory reveals a central lesson. Tensions between individual liberty and collective health are historically persistent. Public health in developed countries evolved through crisis, political negotiation, scientific advancement, and moral commitment to collective well-being. Its trajectory reveals a central lesson. Developed country public health systems are products of social reform, not purely medical innovation.